Imagine this scenario for a moment. You are standing at the pharmacy counter,
Right.
and you are holding your breath. Your heart is pounding a little bit in your chest.
Because you are terrified of what the pharmacist is about to say.
Exactly. You just got a prescription for a life-saving medication, something you or maybe a loved one absolutely needs to survive. The pharmacist taps a few keys. They look at the screen, and then they look up at you with this sympathetic wince.
Oh, that is the worst feeling.
It is. And they tell you your total is $800
Wow.
for a 1-month supply. You feel that sinking sensation in your chest, that sudden panic of wondering how on earth you're going to pay the rent, buy groceries, and afford to stay alive all at the exact same time.
It is a terrifying reality for so many people.
Welcome to the Deep Dive. We are so glad you are joining us today because that terrifying scenario at the pharmacy counter is not just some hypothetical fear.
Not at all.
It is the lived reality for millions of Americans navigating a system that often feels like it was designed to confuse and just completely bankrupt them.
Yeah, it really does feel intentional sometimes.
Today, we are looking at the radical ongoing transformation of the United States pharmaceutical supply chain, specifically looking at 2025 and 2026.
It is a massive shift.
It is. And we have a huge stack of sources to get through to make sense of all this. We are pulling from deep industry analyses from publications like Drug Channels and Pharmaceutical Commerce.
We also have some incredible peer-reviewed academic studies to look at today.
Right, from JMN Network Open. Plus, we've got government policy updates and direct, unfiltered insights from the Cuban Cost Plus drug company.
A lot of ground to cover.
So our mission for this deep dive is to decode exactly why prescription drugs cost so much in the U.S. I mean, prices here are historically 2.5 times higher than in 32 other comparable countries.
Which is just staggering when you really think about it.
It is. We are going to examine the opaque mechanics of how middlemen manipulate the system. And most importantly, we want to see what new transparent business models and this massive shift to domestic manufacturing actually mean for you.
Right, for your wallet and your healthcare.
And the broader economy. Okay, let's unpack this. We have an ecosystem that feels fundamentally broken to the person standing at the register.
Absolutely broken.
But it is clearly functioning exactly as intended for a select few behind the scenes. We are essentially looking at a war between an entrenched, shadowy status quo and a transparent physical rebellion.
That is a great way to put it.
But to understand the rebellion, we really have to diagnose the underlying disease of the current system first.
Well, the underlying disease is entirely rooted in information asymmetry. And really just the sheer dominance of intermediaries.
Okay, break that down for us.
Sure. So if you look at the traditional drug supply chain on a whiteboard, it sounds relatively straightforward.
Manufacturer makes a drug.
Right. A pharmaceutical manufacturer makes a drug and sets a list price. Then a wholesaler buys it, moves it across the country, and distributes it.
And finally, a pharmacy stores it on a shelf and dispenses it to you.
Exactly. It sounds simple. But sitting right in the middle of that flow, extracting immense value without ever actually touching a single pill, is the pharmacy benefit manager.
The PBM.
The PBM. And right now, 3 major PBMs completely dominate the market. You have CVS Caremark, OptumRx, and Express Scripts.
They control the vast majority of the volume.
They do. And they operate using pricing metrics that sound incredibly official but are highly malleable. Specifically, they use the average wholesale price, or AWP.
And the wholesale acquisition cost, right?
Right.
The WAC.
Exactly.
But how do those metrics actually function in the real world? Because to the average person, average wholesale price sounds like a very fixed objective number.
Right. Sounds official.
It sounds like the price you would pay if you walked into a giant warehouse club to buy bulk paper towels. How are these entities manipulating something that sounds so standard?
Think of the average wholesale price, less like an objective cost and more like the sticker price on a new car at a dealership.
Okay, nobody actually pays the sticker price.
Right, nobody pays it, but the entire industry uses it as a baseline to calculate artificial discounts. What's fascinating here is how that baseline enables what economists call the rebate distortion.
The rebate distortion. Okay, explain that.
So PBMs negotiate massive rebates from drug manufacturers. We are talking generally between 85 to 88% off that inflated average wholesale price.
88% off.
Yes. The PBM goes to the drug maker and essentially says, hey, if you want your drug on our approved list so that millions of insured patients can actually get it, you need to give us a massive rebate off your list price.
And the manufacturer just says yes.
They have to comply if they want volume. But to protect their own profit margins, they artificially inflate the list price of the drug in the first place.
Just to create room for the massive rebate.
Exactly.
So wait, the manufacturer raises the price from, say, $10 to $100.
Yeah.
Just so the PBM can demand an $85 discount and run around claiming they saved the system money.
That is exactly how it works.
That is absurd. But where does that $85 actually go? Does it go back to the patient at the pharmacy counter?
Rarely. Conventionally, the PBM keeps a percentage of the rebate they negotiated before passing the rest on to the employer or the health plan sponsor.
Let's look at the math provided in these industry analyses to really nail this down.
Sure. Let's assume a hypothetical generic drug has an AWP of $100.
Okay, $100 on paper.
The PBM negotiates that massive discount, bringing the actual acquisition cost of the drug down to $15.
So they knock $85 off.
Right. But the PBM decides to keep a percentage of that original AWP rebate for themselves.
Just for doing the negotiation?
Yes. So suddenly, the price of the drug billed to the payer is $23.50. The PBM just pocketed $8.50 on a drug that only cost $15 to acquire.
They extracted more than 50% of the drug's value just for processing a transaction.
Precisely.
That seems like an unsustainable grift to me.
Yeah.
If employers and health plan sponsors are the ones actually footing the bill for this, why wouldn't they just look at the contract, see the $8.50 being skimmed, and demand a better deal?
Because they can't see it.
They can't see their own contracts.
The contracts are notoriously opaque. Large PBMs have created entirely new layers of subsidiary entities specifically to obfuscate the money trail.
What kind of entities?
They set up organizations called rebate aggregators or group purchasing organizations, and many of these entities are purposefully domiciled internationally.
Like overseas?
Yes, in places like Switzerland or Ireland, and they do this specifically to prevent domestic audits and avoid transparency requirements.
That is unbelievable.
Estimates suggest another 8% of rebates might be captured right at this international subsidiary level.
So that hypothetical $15 drug is now costing the system over $30.
Easily. The list prices are artificially inflated, the rebates are squeezed out, and the money just vanishes into offshore entities before the employer ever sees the final accounting.
It's a black box.
It is. And on top of that, PBMs charge a litany of fees to the pharmaceutical companies.
Or fees.
Oh, yeah. As of 2021, 29% of PBM revenue was estimated to come strictly from administrative fees.
29%.
Yes. That is a massive jump from 15% back in 2015.
What are they charging for?
Promotional allowances, implementation allowances, formulary placement fees, data fees. It is literally a toll booth on every single inch of the supply chain.
Mark Cuban recently wrote a guest post on the Drug Channel's blog outlining this exact dysfunction.
It was a very pointed post.
He laid out a framework of major criticisms against how these big PBMs operate. And you just hit on the first one perfectly. Absolute zero transparency.
Right. You can't see the math.
He noted that the primary rule of contracting with a PBM is that you are legally barred from talking about the PBM or the specifics of their contracts.
It's like Fight Club rules.
Exactly.
Yeah.
Providers, manufacturers, employers, and non-affiliated pharmacies are all legally gagged.
It protects the margin.
But he also talked about how this impacts the physical categorization of the drugs themselves. He used the term magic names.
Magic names, yes.
How does a PBM magically rename a drug to extract more money?
They utilize their absolute control over the formulary, the master list of covered drugs.
Right.
A PBM can take a standard small molecule generic drug that has been on the market for years, and they just arbitrarily reclassify it as a specialty drug.
Is there a medical reason for that?
Often there is absolutely no clinical justification for it. The drug doesn't suddenly require complex refrigeration or special handling.
It's the same exact pill.
Same pill. But by slapping the specialty label on it, the PBM can force the patient to bypass their local community pharmacy.
And mandate that they use a mail-order specialty pharmacy.
Exactly, a specialty pharmacy that is wholly owned by the PBM itself.
Ah, so they force the volume to their own subsidiary.
Yes, and once the drug is channeled through their captive, wholly owned pharmacy, they can charge the health plan exponentially more than the drug is actually worth on the open market.
Because there's no competition.
None. They dictate the rules of the game, and they own the board the game is played on.
Let's ground this in a real-world example so you listening can truly grasp the scale of the financial pain this causes. Let's look at the chemotherapy drug Imatinib.
The generic version of Gleevec.
Right. It's a leukemia treatment. It has been around for a very long time. It is a standard generic small molecule pill.
Nothing fancy about the physical pill itself?
If a patient gets diagnosed with leukemia and they happen to be on a high-deductible health plan, what does this PBM pricing maze look like for them when they try to get this life-saving generic?
Under the traditional convoluted PBM system, the adjudicated price can be staggering.
The adjudicated price, meaning the final price negotiated by the PBM that the patient is responsible for before they hit their deductible.
Correct. A patient might be asked to pay anywhere from $2,000 to $3,200 for a single one-month supply of generic Imatinib.
Over $3,000.
For a generic, yes, that is thousands of dollars out of pocket. The system requires the patient to absorb the inflated list price until their massive deductible is fully met.
And this brings up a massive point of friction. If an employer signs a contract with a PBM, they might think they're getting a great deal because the PBM promises them a large rebate check at the end of the year.
They love that rebate check.
Right. And the employer uses that check to lower the overall healthcare premiums for the entire company.
Yeah.
But who is actually funding that rebate check? It isn't the drug manufacturer just freely handing out cash from their vault.
Not at all. And if we connect this to the bigger picture, the reality of corporate healthcare financing is deeply troubling.
How so?
Those rebates are largely paid for by the sickest and oldest employees within a given company.
Explain the mechanics of that.
Because the list prices are kept artificially high to fund the rebate structure employees with chronic conditions, they hit their high deductibles very quickly.
Like the leukemia patient needing Imatinib.
Exactly. Or someone managing diabetes or rheumatoid arthritis. They are paying those inflated thousands of dollars prices out of pocket.
Using their own after-tax income.
Yes. The PBM aggregates that overpayment, takes its cut, and hands the remainder back to the employer.
And what does the employer do with it?
The employer then applies that money to lower the monthly premium for the 25-year-old employee who never goes to the doctor.
Wow. So essentially, healthcare within the modern corporate structure functions as a regressive tax.
A massively regressive tax. The sick employees are actively and disproportionately subsidizing the healthcare costs of the healthy employees.
While the PBM skims a massive multi-billion-dollar margin off the top just for facilitating the transfer.
It is incredibly efficient for the PBM, but devastating for the patients.
When you map out the mechanics like that, it is genuinely enraging. The sickest people at the absolute most vulnerable moments of their lives are being used as a funding mechanism for corporate premium reductions and offshore middleman profits.
It is hard to justify when you see the math bear like that.
Cuban also pointed out how this system financially abuses independent community pharmacies.
The mom-and-pop shops.
Right. They are subjected to aggressive audit tactics and forced to accept reimbursement rates that are often lower than the cost they paid to acquire the drug in the first place.
They're forced to take a loss just to serve their patients.
But diagnosing the disease is only the first step. The market is finally responding.
We're seeing real pushback.
A massive structural pushback against this opaqueness. Let's look at the emergence of the un-PBM model, specifically the Mark Cuban cost-plus drug company.
MCC-PDC.
They are trying to build an entirely parallel supply chain. How is their corporate structure fundamentally different from the incumbents we just talked about?
Well, MCC-PDC was founded in 2022 by Dr. Alexander Oshmyansky and Mark Cuban, and it operates as a public benefit corporation, or PBC.
A public benefit corporation. Why does that specific legal designation matter so much?
Because that legal designation is the foundation of everything they do. A traditional C corporation, like a major PBM, has a fiduciary duty solely to maximize shareholder value.
Meaning they have to make as much money as legally possible.
Right. If a traditional PBM can legally extract an extra $1 billion by hiding fees in an offshore aggregator, they are essentially obligated to do so for their shareholders.
But a public benefit corporation is different.
Radically different. The legal charter mandates that their social mission must be prioritized alongside and sometimes even above pure financial performance.
And their social mission here is improving public health through transparent, affordable medicine.
Exactly. So they have fundamentally rejected the rebate-centric model. They don't negotiate rebates. They don't have offshore aggregators.
They just built a vertically integrated direct-to-consumer supply chain.
Using a strict cost-plus economic model.
The formula for this cost-plus model is almost jarringly simple when you compare it to the convoluted average wholesale price and wholesale acquisition cost metrics we just discussed.
It takes 10 seconds to explain.
It is literally just the actual acquisition cost of the drug, what they paid the manufacturer to make it or buy it, plus a fixed 15% markup to fund their operations.
Plus a flat $5 pharmacy labor fee.
And a flat $5 shipping fee.
That is the entire equation.
No hidden implementation fees.
Yes.
No formulary placement kickbacks.
None.
If we go back to that leukemia drug, Imatinib, which was costing the patient on the high deductible plan up to $3,200 a month under the traditional system, what does that exact same pill cost through this transparent model?
On the Cost Plus Drugs platform, that exact same 1 month supply of Imatinib costs between $13.40 and $35.10.
$13 instead of $3,000.
You are looking at a savings of well over 90%.
The financial toxicity is completely removed from the equation.
Entirely.
And their ability to scale this model has been really significant. They launched with roughly 100 essential medications.
And they grew very fast.
They quickly scaled to over 2,200. And today they carry over 2,500 different medications.
They cover almost everything.
Right, from cardiovascular health and infectious diseases to oncology and dermatology.
The data in dermatology is particularly striking in the reports.
Yes, a recent analysis showed that MCC-PDC costs averaged roughly $17 for certain common dermatology prescriptions.
And if you compare that to traditional discount coupon platforms,
For ones that still rely on the convoluted PBM network to generate their prices, the average cost there was over $31.
almost double the cost, even with a discount coupon.
Exactly. But it isn't just a handful of anecdotes or cherry-picked generic price drops.
The academic community is actively auditing this model to see if it holds up at scale.
Yes. There was a major study published recently in JAMA Network Open that really dug into the math on a systemic level.
JAMIT is about as rigorous as it gets.
They looked at a specific cohort of medications to see how the transparent cash model stacked up against heavily negotiated commercial insurance rates. What did the researchers actually find when they ran the numbers?
The JAMA Network Open study is a crucial piece of validation for the model. The researchers analyzed 33 different neurological medications.
Neurological drugs are often chronic maintenance medications, right?
Exactly, things for seizure disorders, Parkinson's, or severe migraines. So the cumulative cost burden for these patients is naturally very high.
So they compare the costs paid by third-party commercial insurance plans, which utilize PBMs, against the cash prices paid by patients using cost-plus drugs.
Right, and the primary finding was that MCC-TDC consistently delivered lower total system costs across the board.
Lower total system costs.
Yes, the fundamental cost of acquiring and dispensing the drug was consistently cheaper without the middleman extraction.
Total system cost is a vital concept for us to highlight here. That means the patient's out-of-pocket cost at the pharmacy counter, combined with whatever massive balance the insurance plan paid behind the scenes.
It is the actual true cost of the drug to society.
But here's where it gets really interesting. The JAMA study revealed a bizarre, almost counterintuitive paradox in the data.
The paradox is fascinating.
For some of these neurological medications, patients who actually had good commercial insurance paid more out of pocket using the cheap, transparent cost-plus model than they would have if they just went to their local pharmacy and used their traditional insurance copay.
It seems completely backward at first glance.
The researchers noted that it was difficult to pinpoint exactly why the direct-to-consumer model achieves lower total costs for the system, but sometimes resulted in higher immediate out-of-pocket costs for insured individuals. Why does that happen?
It seems paradoxical until you understand the psychology of benefit design.
The psychology of it.
Yes. Traditional insurance plans subsidize the immediate cost for the end user at the pharmacy counter. They do this to insulate the patient from the true cost of the system.
Okay, let's walk through an example of that.
Let's say a drug has a massively inflated list price of $400. The PBM negotiates it down to $200, keeps $50, and bills the health plan $150.
Okay, so the health plan is out $150.
Right. But the health plan allows the patient to pick up the drug for a flat $10 copay.
So the patient feels great. They got a $400 drug for $10.
Exactly. Meanwhile, the system is bleeding capital, driving up everyone's monthly premiums year over year just to cover that hidden $150 charge.
But the patient doesn't see that on Tuesday when they pick up the pill.
They never see it. Now, the cost-plus model might acquire that exact same drug and sell it for a transparent flat rate of $15 total.
So the total system cost drops from $150 to $15. That is a massive win for society.
It is. But to the individual patient standing at the counter, Their choice is either a $10 copay with their insurance card or a $15 cash payment at cost plus.
So the patient is essentially asked to act against their own immediate financial interest for the greater good of the overall system.
Which is a very hard sell.
If my copay is $10, I am going to use my copay. I am not going to voluntarily pay $15 cash just to save my giant insurance company $150 in the background.
Exactly. It asks the consumer to bear the friction of systemic reform.
That is a tough hurdle.
It is exactly the friction we are seeing play out. The individual patient feels insulated at the exact moment of purchase. If they prioritize their immediate subsidized copay over the macro health of the healthcare system, the transparent model really struggles to capture that insured volume.
Why would I pay more out of pocket even if my insurance company is being completely gouged in the background?
The traditional system relies heavily on that apathy. It relies on the patient not caring what the drug actually costs to the system, as long as their specific individual copay is low.
Overcoming that psychological hurdle is the biggest challenge for the cost-plus model in the insured market.
Without a doubt.
And there is another massive limitation to the direct-to-consumer mail order model. Mail order is fantastic for chronic maintenance medications.
If you take a statin for your cholesterol every single day, getting a 90-day supply in the mail works perfectly.
But healthcare is often acute and immediate. If you wake up and your child has a raging fever and strep throat, you cannot log onto a website, request a prescription transfer, and wait 3 to 5 business days for an antibiotic to arrive in the mail.
You need that amoxicillin right now, today.
The internet cannot solve acute physical illness.
Yeah.
So cost-plus drugs had to evolve. They had to figure out a way to step out of the digital space and integrate into the physical brick-and-mortar world.
Which brings us to their physical retail alliances and the rollout of the Team Cuban card.
This is a really necessary evolution.
It was. It started as a relatively contained pilot program specifically for employees of the Dallas Mavericks and the various Mark Cuban companies.
They just wanted to test the waters.
They wanted to test if they could actually bring transparent pricing to a physical register. And it worked. And it has since expanded massively.
How massive are we talking?
Patients can now present their Team Cuban card, which functions essentially like a transparent benefit card at over 17,000 participating pharmacies across the country.
17,000. That isn't just a niche network of small mom-and-pop shops.
No, it includes massive national grocery chains, Kroger, Albertsons, Meijer Publix, and Food Lion, operating right alongside independent community pharmacies.
So they are building a parallel network within the existing infrastructure.
A parallel transparent network.
But if they're using the physical retail space, they can't just charge a flat $5 shipping and $5 labor fee like they do online.
No, the economics are totally different.
Right. Running a massive grocery store pharmacy or an independent shop is vastly different than running a centralized mail-order warehouse. How does the transparent cost-plus math adapt to the physical register?
The pricing model maintains its absolute transparency, but the variables adjust to reflect the reality of retail overhead.
Okay, walk us through the new variables.
If a patient walks into an affiliate pharmacy and hands over the Team Cuban card, the pricing structure is calculated precisely. It is the wholesale acquisition cost of the drug plus that standard 15% markup for cost plus.
Okay, that part is the same.
Plus a flat $12 baseline dispensing fee that goes entirely and directly to the physical pharmacy.
$12 straight to the pharmacy.
Yes. Plus a $1 processing fee to run the network transaction.
Let's break that down with a real-world example from the retail data.
Let's look at fluoxetine.
Say a patient needs 30 capsules of 20 milligram fluoxetine, which is the generic equivalent of Prozac.
The acquisition cost on the wholesale market is 57 cents. The 15% markup on that 57 cents is roughly 8 cents.
And then you add the $12 dispensing fee for the pharmacist and the $1 processing fee.
The total cost to the patient at the register is exactly $13.65.
That $12 dispensing fee seems like the absolute linchpin of this entire physical strategy.
It is the entire ballgame for retail.
For decades, independent pharmacies have been screaming that PBMs reimburse them at rates that literally force them to lose money on every prescription they fill.
They are dealing with retroactive clawbacks constantly.
Right. Those are called DIR fees,
Right.
or direct and indirect remuneration fees, where a PBM will just randomly extract money from the pharmacy months after a drug was dispensed.
Just crushing their margins.
How does a guaranteed $12 fee change the survival calculus for an independent pharmacist.
It is literally the difference between keeping the lights on and closing the doors forever.
Give us some precise context on that.
Let's look at the operational reality for an independent owner. Take Tara Schneider. She's a pharmacist who owns and operates Middletown Pharmacy in Kentucky.
Okay.
She provided an analysis of her profit margins under traditional PBM contracts versus this transparent model.
What did the numbers show?
She pointed out that when she fills a standard 30-day supply of the generic acid reflux drug pantoprazole under a traditional major commercial insurance plan like United Healthcare, her pharmacy nets a profit of exactly $1.38.
$1.38 to stock the drug consult with the patient, process the complex insurance claim, and dispense the medication safely.
Yes. Compare that $1.38 to the guaranteed unclawable $12 she makes under the Team Cuban card.
That is a night and day difference.
Furthermore, for cold chain drugs that require heavy refrigeration or drugs with complex FDA risk evaluation and mitigation strategies known as REMS.
Drugs that require extensive pharmacist monitoring.
Exactly. For those complex drugs, the fee goes up to $14. PBMs have been squeezing independent pharmacies to the point of bankruptcy, creating massive pharmacy deserts in rural and low-income areas.
And this transparent, flat fee model offers them a sustainable, predictable way to actually stay in business.
It is a profound shift for the retail landscape.
The vast majority of patients, some surveys say around 85%, still prefer getting their prescriptions from a physical brick-and-mortar pharmacy rather than an anonymous mail-order facility.
People want to establish a relationship with their pharmacist?
They do. They want to be able to ask questions about drug interactions. They want immediate care when they are sick. And now this parallel network allows them to get that care without getting completely gouged.
While ensuring the independent pharmacist actually makes a living wage for their clinical expertise.
It feels like a massive victory. But we have to acknowledge a hard truth about the pharmaceutical market. As amazing as these savings on generic pills are, the generic market is only a fraction of the total spending.
That is unfortunately very true.
The real financial toxicity, the overwhelming burden that crushes health plan budgets, lies in what the industry calls specialty drugs.
That is correct. While small molecule generic drugs make up over 90% of the actual physical prescriptions filled in the United States, they account for a relatively small percentage of the total national drug spending.
The real money, the billions upon billions of dollars that drive the PBM profit engines, is heavily concentrated in specialty medicines.
And these are not simple chemical compounds pressed into a pill.
No, they are incredibly complex, often biologic drugs.
Biologics are essentially large, highly complex molecules manufactured inside living systems, like microorganisms or specially engineered plant or animal cell lines.
They are notoriously difficult to manufacture, highly sensitive to temperature and handling, and they are used to treat severe chronic and complex conditions.
Things like rheumatoid arthritis, severe plaque psoriasis, Crohn's disease, and various forms of cancer.
And precisely because their list prices are so astronomically high, often tens or hundreds of thousands of dollars a year, they are the primary battlefield for PBM rebate negotiations.
The fact that MCCPDC is now aggressively entering this highly guarded specialty space is a monumental shift in strategy.
And their weapon of choice to breach this fortress is the biosimilar.
The biosimilar, yes.
For the listener, a biosimilar is conceptually akin to a generic version of a biologic drug. It isn't chemically identical because you are dealing with living cells.
Right, you can't perfectly clone a living cell batch.
But the FDA certifies that it has no clinically meaningful differences from the highly expensive original reference drug.
The sources point to a massive new addition to the cost-plus portfolio that illustrates this perfectly.
They have added a drug called Stargemza. This is a biosimilar for a massive blockbuster inflammatory drug called Stelara.
Stelara has historically cost patients and health plans tens of thousands of dollars a year. It is a massive line item on any corporate health budget.
What is Cost Plus Drugs listing this biosimilar for?
They are completely bypassing the traditional specialty pharmacy markup. Cost Plus Drugs is listing Stargemza at a starting price of $345 per quarter for a pre-filled syringe.
$345 a quarter.
That represents an astonishing 99% drop from the reference biologic's original list price.
That is insane, a 99% drop.
They're taking a drug that used to define financial toxicity for autoimmune patients and pricing it like a standard mid-tier generic.
That is a staggering price collapse.
Yeah.
But the traditional PBMs aren't just going to sit back and let their most profitable revenue streams evaporate overnight.
Oh, definitely not.
They control the formularies. They control what the insurance plans actually cover. If we look at how the massive incumbents are reacting to the introduction of these cheap biosimilars, it exposes a lot of the hypocrisy in the system.
If we connect this to the bigger picture of corporate strategy, the launch of Stargemza exposes the deep systemic dysfunction of the traditional drug channel.
Let's talk about Express Scripts. How is a giant like Express Scripts handling the formulary placement for Stelara and its biosimilars as we head into 2026?
We have a detailed report from Drug Channels analyzing Express Scripts' national preferred formulary strategy for 2026.
What are they doing?
On the surface, Express Scripts is taking what looks like a positive step. They are removing the massively expensive original reference product Stelara from their preferred formulary, forcing patients toward biosimilars.
Well, that sounds like a win for the system on paper.
On paper, yes, but the mechanics of how they are doing it maintain a bizarre pricing double standard.
What kind of double standard?
They're adding cheap, deeply discounted biosimilars to the list, yes, but they are also giving preferred co-equal placement to a much higher-priced private label version of the exact same biosimilar.
A private label version?
Yes. This higher-priced version comes from a company called Quallent Pharmaceuticals, which is essentially sourcing the drug from Samsung BioAbyss.
And what's the catch with Quallent?
The catch is that Quallent is a private label subsidiary heavily affiliated with the PBM ecosystem itself.
Okay, let me make sure I'm following the shell game here. The PBM is pushing a cheap version of the drug onto the formulary.
Right.
But right next to it, they're pushing a vastly more expensive version of the exact same clinical drug produced by a company that is affiliated with the PBM's own corporate structure.
That is exactly what they're doing.
Why on earth would any rational employer or any HR department managing a health plan actively choose the higher-priced biosimilar when a functionally identical cheap one is sitting right there?
Because of the addiction to rebates?
It always comes back to the rebates.
Always. The higher-priced private label biosimilar generates a massive rebate spread. The employer chooses the high list price because they know it comes with a massive rebate check at the end of the quarter.
Which they use to artificially buy down their overall premium costs to make their benefits package look more attractive to employees.
Exactly. And the PBM happily facilitates this because they take a cut of that massive rebate as it flows through their hands.
It's just moving money in circles.
As the prominent industry analyst Adam Fain noted in our research stack, employer plan sponsors suffer from an unrequited love of rebates over lower true prices.
An unrequited love of rebates. That is a brutal assessment.
It is accurate, though. They are completely addicted to the cash flow of the rebate check. They prioritize that cash flow, even if it means their sickest employees are forced to pay heavily inflated coinsurance out of pocket based on the higher list price of the private label drug.
It is a financial shell game that prioritizes corporate balance sheets over patient affordability every single time.
And MCC PDC's entry into the specialty market with a flat, non-negotiable $345 price tag fundamentally threatens this entire shell game.
Because it forcefully exposes to the public exactly what the drug actually costs to manufacture and distribute without the rebate inflation.
It strips away all the plausible deniability.
It is incredible how deep the dysfunction goes and how complicit the employers are in maintaining it just to get a discount on their premiums.
It's systemic.
But pricing manipulation and formulary games are only one side of the coin. The other side, the side that is arguably much more terrifying on a physical level, is actual availability.
The physical supply chain.
Because right now, the United States is dealing with a catastrophic, ongoing physical supply chain crisis. We are literally running out of basic foundational drugs.
The shortage numbers are alarming.
As of the time these analyses were published, there are roughly 200 different drugs in active shortage across the U.S.
200.
And we aren't talking about rare, experimental new therapies that are hard to make. We're talking about critical, decades-old, life-saving generic medications.
Hospitals are running out of albuterol for acute asthma attacks.
They are rationing pediatric chemotherapies for children with cancer. How is it possible that the wealthiest country in the history of human civilization cannot keep basic 60-year-old medicines on the shelf?
The root cause of these physical shortages is complex, but the essential underlying dynamic is a fundamentally dysfunctional market for the physical distribution of pharmaceuticals.
We just spent a lot of time talking about how PBMs control the pricing and insurance side.
But when it comes to the physical purchasing and movement of generic drugs, The market is controlled by a massive bottleneck.
What kind of bottleneck?
Just 3 major wholesaler sourcing programs dominate the entire landscape.
3.
Together, these 3 centralized purchasing entities account for approximately 90% of all generic pharmaceutical purchases from manufacturers in the U.S.
90% controlled by just 3 entities. That is an extreme bottleneck.
It is essentially an oligopsony.
When you have that much concentrated buying power, you completely dictate the terms of survival for the manufacturers. How does that consolidation directly lead to empty shelves in a hospital?
Because generic drugs are viewed by these wholesalers entirely as undifferentiated commodity products.
They don't care about brand loyalty.
They don't care about brand loyalty. They care about the absolute lowest fraction of a cent per pill.
So how do they negotiate?
These massive wholesalers generally utilize group purchasing organizations, or GPOs, to negotiate. They will issue a contract for a specific generic drug, and they almost universally award that massive exclusive contract to a single primary provider.
The lowest bidder.
The absolute lowest bidder. This creates a relentless, ruthless race to the bottom on price.
To win the contract and survive, generic manufacturers have to slash every conceivable operational cost.
They offshore their manufacturing to countries with vastly cheaper labor pools and looser environmental and regulatory oversight.
And they eliminate any redundant manufacturing lines. There is no backup factory.
None. They run their primary facilities at absolute maximum capacity 24 hours a day with zero margin for error.
So the supply chain becomes incredibly brittle and hyperextended.
Exactly.
If you rely entirely on a single factory running at maximum capacity halfway across the world, what happens when reality strikes? If a factory in India or China discovers a bacterial contamination in a clean room, or a hurricane hits a major shipping port, or there is a sudden geopolitical trade dispute,
The whole U.S. supply chain for that specific drug just instantly collapses. There is no slack in the system to absorb the shock.
the vulnerability is staggering.
Industry data indicates that a massive 72% of all the active pharmaceutical ingredient, or API, suppliers for the U.S. market are located overseas.
The API is the actual chemical compound that makes the drug work. We don't even make the raw ingredients here anymore.
When a single overseas supply line goes down due to a failed FDA inspection or a localized disruption, it can take a year or more for a new manufacturing line to be approved, validated, and established to address the shortfall.
And the human cost of this is severe. The rates of morbidity and mortality for certain pediatric cancers in the U.S. have actually gone up in recent years, simply because the baseline generic medications necessary to treat them are physically unavailable.
The system has optimized for cheapness at the absolute expense of resilience.
MCC-PDC, by contrast, is trying to build a resilient model. They currently source roughly 40% of their APIs from strong, highly regulated jurisdictions.
Compared to the broader industry average of just 10%.
But simply sourcing better ingredients from reliable allies isn't enough to solve the physical shortage problem.
Right. So what does this all mean? It means we have to stop relying entirely on vulnerable global networks for our most critical survival tools.
We have to start building our own factories again. We have to bring the manufacturing back home.
And that leads us to the most physical, tangible part of this entire market transformation, the massive return of American pharmaceutical manufacturing.
And specifically, the tip of the spear in this movement is MCC-PDC's Dallas pilot plant.
MCC-PDC recognized very early on that relying on vulnerable offshore supply chains fundamentally contradicted their core mission of reliable, affordable access.
You cannot guarantee a transparent price if you don't actually have the drug to sell.
So they made a massive capital expenditure. They built an $11 million, 22,600 square foot advanced manufacturing plant right in the middle of the Deep Ellum neighborhood of Dallas, Texas.
But this is not your traditional sprawling pharmaceutical factory churning out billions of oral tablets in massive vats.
No, the Dallas facility is highly specialized and incredibly modern. It focuses exclusively on sterile, fill-finish injectables.
These are the specific types of medications that are most frequently landing on the FDA shortage list. We are talking about critical emergency drugs, things like epinephrine for severe allergic reactions.
And norepinephrine, which is absolutely vital for maintaining blood pressure in patients suffering from severe shock in the ICU.
When you look at the descriptions of this facility, it sounds like something out of a science fiction movie. The outside blends right into the Deep Ellum Arts District. It has this vibrant, massive mural featuring a Pegasus intertwined with DNA strands.
But inside it is a masterclass in modern engineering.
You don't see massive open vats or technicians in standard lab coats. You see incredible stainless steel water for injection generation systems, miles of pristine, perfectly welded piping, and these incredibly advanced OptumRx robotic fill finish systems operating completely inside sealed, sterile glass enclosures.
The robotic technology is what makes this plant truly revolutionary. It completely removes the human element from the sterile environment, which drastically reduces the risk of contamination.
The facility utilizes single-use disposable components, meaning they don't have to spend days scrubbing and sterilizing permanent steel pipes between drug runs.
They use robotic arms to handle the vials and AI machine vision systems to monitor product quality and particulate matter in real time.
In a traditional legacy pharmaceutical plant, changing a massive manufacturing line from producing one drug to producing a completely different drug can take months.
You have to shut the entire system down, perform exhaustive cleaning, sterilize the equipment, run validation batches, and often wait for new regulatory sign-offs.
The advanced robotic systems in the Dallas plant are designed for hyper-agility. They can pivot the entire manufacturing line to address a sudden national drug shortage in just 4 hours.
4 hours. That is mind-blowing agility.
A hospital could announce they are out of emergency epinephrine on a Tuesday morning, and by Tuesday afternoon, a factory in Texas is already spinning up a line to replace it.
How is that even possible from a regulatory standpoint? Doesn't the FDA require mountains of paperwork before you can just switch production?
They achieve this unprecedented speed, partly through the robotic technology, but equally through a very specific regulatory strategy.
The Dallas facility operates under a special FDA designation known as a 503B outsourcing compounding site.
What does that designation allow them to do?
This designation was created under the Drug Quality and Security Act to bridge the gap between small-time neighborhood compounding pharmacies and massive, rigid drug manufacturers.
Operating as a 503B facility allows them to legally manufacture and distribute large batches of drugs that are currently listed on the FDA's official shortage list.
Without having to go through the years-long traditional new drug application process for every single batch.
It gives them the legal flexibility to rapidly pivot and manufacture whatever the market desperately needs that week,
while still maintaining full compliance with strict current good manufacturing practices.
Right now, the pilot facility's capacity is estimated at roughly 1 to 2 million sterile doses a year.
That is enough volume to completely alleviate acute shortages for 4 or 5 large regional hospital systems.
But they view this as just a proof of concept. They already drafted blueprints for a massive $300 million expansion facility capable of producing over 100 million sterile units annually.
A facility of that monumental scale could theoretically alleviate the majority of acute sterile drug shortages across the entire United States.
But to build a $300 million mega plant, you need massive capital injection. And you need the broader regulatory environment to actively cooperate with your expansion.
Which is exactly why Mark Cuban has been very publicly pushing the government to change its fee structures.
Specifically advocating for the waiver of the FDA generic drug approval fee.
The general public probably doesn't realize this, but it costs a fortune just to ask the government for permission to make a generic drug.
Right now, a manufacturer has to pay roughly $360,000 in user fees just to get the FDA to review an application to produce a generic medication that has already been proven safe for decades.
Cuban argues that waiving this exorbitant fee for domestic producers would drastically lower the barrier to entry,
allowing companies to rapidly expand production into low-margin rare disease drugs and other critical shortage areas without taking a massive financial hit just on the paperwork.
And this push for domestic manufacturing isn't just a pet project of Mark Cuban. It isn't happening in a vacuum.
If we zoom out and look at the macro trends, the MCPDC Dallas plant is just the vanguard of a much larger historic boom in domestic pharmaceutical manufacturing spanning 2025 and 2026.
The entire global industry is experiencing a paradigm shift.
They are collectively recognizing that the era of hyperglobalized, brittle supply chains prioritizing absolute lowest cost over reliability is over.
The capital commitments being made by the major players right now are staggering.
The numbers coming from the industry trackers are genuinely historic. We are talking about Hundreds of billions of dollars being poured into American soil to build factories.
Merck is committing over $70 billion for domestic investments, which includes building a massive new manufacturing center of excellence.
Eli Lilly is pledging $27 billion to construct 4 advanced megasites.
AstraZeneca just unveiled a $50 billion investment plan.
Johnson & Johnson is committing $55 billion. Why is the entire industry suddenly rushing to build massive, expensive factories in the U.S. all at the same time?
There is a confluence of powerful drivers behind this macro shift. First and foremost is the lingering supply chain trauma of the pandemic.
Companies realized that relying on a single factory in a geopolitical rival's territory is an existential threat to their business.
They are forced to prioritize physical resilience. Second, there is a massive surging shift in consumer demand.
We are seeing the explosion of novel complex therapies, specifically the new class of GLP-1 obesity and diabetes drugs.
Along with incredibly advanced treatments like CAR T-cell therapies and gene therapies.
These are not simple pills. They require high-capacity, highly sterile bioprocessing environments that are vastly better suited for strict domestic oversight and a highly educated local workforce.
Third, macroeconomic and geopolitical tensions are forcing the issue. The threat of sweeping trade policies and tariffs is very real.
Current analyses suggest that proposed U.S. tariffs could potentially add up to $19 billion in excess costs to the global pharma supply chain.
It makes immense financial sense for these multinational companies to build locally, to avoid those massive penalties and ensure uninterrupted access to the lucrative American market.
And the federal government isn't just sitting back. They are actively greasing the wheels to accelerate this onshoring.
They know that building a bioprocessing plant is a regulatory nightmare that usually takes years.
In May of 2025, a sweeping executive order was passed, specifically directing the FDA to slash red tape and streamline the approval processes for U.S.-based drug manufacturing plants.
And they followed that up in August of 2025 by launching the FDA PreCheck initiative.
This program provides pharmaceutical companies with early, frequent, direct communication and feedback from regulators during the actual construction and process design phases of the facility,
drastically accelerating the timeline from breaking ground to fully operational production.
However, this massive industrial shift raises a critical, potentially troubling question for you, the listener, to consider regarding the future of your pharmacy bill.
Onshoring undeniably fixes the physical shortage risk. It undeniably fixes the severe quality control issues that stem from poorly regulated offshore factories.
But operating a high-tech facility with American labor, paying American wages, and adhering to strict domestic EPA and OSHA standards is fundamentally and permanently more expensive than running a sweatshop factory overseas.
Analysts are warning that these heightened permanent domestic manufacturing costs, combined with the hundreds of billions of dollars currently being spent on capital expenditures to build the plants, could ultimately raise the baseline floor price of generic drugs across the board.
So the crucial question becomes, will the massive savings generated by eliminating the greedy PBM middlemen be enough to offset the structurally higher costs of domestic manufacturing?
Can we actually have a system that provides resilient, high-quality American-made drugs that are still affordable for the average citizen?
That is the multi-billion-dollar question that will define the next decade of healthcare.
And while the physical supply chain is rebuilding itself from the ground up, the intricate insurance landscape is simultaneously fracturing under the weight of new complex legislation.
We really need to pivot and look at what is happening with the government's role in this, specifically Medicare Part D.
Because the unintended consequences of recent policy are hitting seniors incredibly hard right now.
According to deep granular analysis from our industry sources, the Medicare Part D standalone prescription drug plan market is essentially undergoing a collapse.
And this collapse is a direct, albeit unintended, result of the Inflation Reduction Act, or the IRA.
The IRA was celebrated for capping out-of-pocket costs for seniors. But to achieve that, it fundamentally redesigned the liability structure for the insurance plans themselves.
Prior to the IRA, if a senior had catastrophic drug costs, the federal government Medicare absorbed roughly 80% of that liability in the catastrophic phase.
The IRA flipped that entirely. It capped the seniors' out-of-pocket spend, but shifted massive financial liability directly onto the private insurance plans,
forcing them to absorb roughly 60% of those catastrophic costs.
So the government told the private insurance companies, we aren't covering the worst-case scenarios anymore, you are.
How did the massive insurance companies react to suddenly being on the hook for billions of dollars in new liability?
They bailed. They aggressively exited the market or consolidated their offerings to shed risk.
In 2026, there will be only 360 standalone prescription drug plans available nationwide.
That represents a massive 22% drop in available plans from just 2025.
And the resulting market consolidation is terrifying from a competitive standpoint.
Just four massive companies, Centene, HCSC, Humana, and United Health, will control a staggering 84% of the entire prescription drug plan market.
With drastically less competition and substantially higher liabilities, these remaining plans are aggressively shifting costs wherever they legally can.
Seniors are facing higher deductibles right out of the gate, and a much greater reliance on steep coinsurance percentages for non-specialty brand drugs.
The bitter irony is that if a Medicare beneficiary doesn't have catastrophic costs, if they don't hit the new $2,000 annual out-of-pocket cap, they may actually end up paying significantly more for their daily routine medications this year than they did before the reform was passed.
It is incredibly frustrating to watch. You pass sweeping legislation with the intent to help vulnerable people, and the market just contorts itself, consolidates power, and squeezes them somewhere else to maintain profit margins.
We are also seeing a similar distortion with the 340B drug pricing program.
This was originally a very targeted program designed specifically to help true safety net hospitals buy drugs at a steep discount so they could afford to serve uninsured and vulnerable populations.
But recent reports show the program is expanding wildly beyond its original intent.
It is being driven by the strategic choices of massive wealthy hospital systems aggressively buying up independent wealthy suburban clinics just so they can claim the 340B discount across a wider patient base.
This rampant vertical integration is fueling higher federal spending and actively raising costs for commercial payers in the private market.
In this incredibly chaotic, rapidly shifting environment of collapsing insurance markets and expanding loopholes, alternative tech solutions and policy partnerships are becoming vital survival strategies.
That is exactly right. Innovative disruptors like MCC-PDC aren't just relying on their brick-and-mortar pharmacy alliances and a single manufacturing plant in Dallas.
They are heavily leveraging advanced technology to scale their operations efficiently.
They recently formed a major partnership with a company called MedChat.ai to deploy sophisticated artificial intelligence customer care agents.
When you are running a direct-to-consumer healthcare model that serves millions of patients, patient support is critical. People have questions about their prescriptions.
AI allows them to scale that support infinitely and instantaneously without exponentially increasing their human overhead costs.
Which is absolutely vital for maintaining that incredibly slim, transparent 15% profit margin.
They have also formed strategic alliances with other domestic manufacturers like Alcom Laboratories to specifically focus on using automated AI-driven platforms to onshore the production of highly essential, vulnerable medicines.
Targeting specific shortage drugs like lidocaine and diltiazem.
And we absolutely cannot discuss the landscape of 2026 without addressing the massive shifts in the political landscape.
Now, just to be absolutely clear to you, our listener, we do not endorse any political viewpoints, candidates, or administrations on this deep dive.
Right. Our mandate is strictly to analyze the factual policy framework and the economic market reactions precisely as they are presented in the data.
With that strict impartiality in mind, a major development rocking the industry is the announcement of the TrumpRx partnership. What exactly is the mechanism of this new program?
The OptumRx platform, which is slated to launch in early 2026, is fundamentally designed as a government-sponsored direct purchasing search engine.
It is crucial to understand that it is not a direct seller or a physical distributor of drugs itself.
Instead, it acts as a massive referral hub that directs patients toward transparent direct-to-consumer websites like Cost Plus Drugs.
The underlying strategy is to use the immense reach of a government platform to drive massive consumer volume toward these transparent, low-cost options, theoretically starving the opaque PBMs of their transaction volume.
Pfizer was notably one of the first major legacy pharmaceutical manufacturers to publicly sign on to this initiative.
And the geopolitical angle here is deeply intertwined. By joining the TrumpRx hub, Pfizer successfully secured a 3-year grace period during which its imported products will not be subject to the sweeping new tariffs,
allowing them to avoid billions in those supply chain penalties we discussed earlier.
It is fascinating to see how policy tariffs and direct-to-consumer models are all colliding. Mark Cuban's public reaction to the TrumpRx announcement was really interesting to dissect.
He essentially gave the program a B grade on social media.
His reasoning for the slightly muted grade was based on market indicators. He noted that the stock prices of the major publicly traded PBMs didn't immediately plummet when the platform was announced.
To him, that implies the broader financial market doesn't believe the big middlemen are facing an immediate existential threat from a search engine.
However, Cuban also pragmatically noted that being listed on a massive government referral hub will undeniably drive massive new patient volume directly to cost-plus drugs.
And in his strict cost-plus economic model, higher volume directly equates to greater purchasing power, which ultimately results in even lower acquisition costs for patients.
But prominent industry analysts remain highly cautious about the ultimate systemic impact.
In the research, Jesse Mendelsohn, a senior executive at the revenue management firm Model N, pointed it out that the true long-term impact of TrunkRx remains to be seen.
His core argument is that the vast, overwhelming majority of Americans still fundamentally rely on their commercial insurance to pay for their drugs.
A direct-to-consumer search engine is a fantastic tool that vastly expands access for the uninsured or for patients who are willing to pay cash outside of their high deductibles.
But it doesn't fundamentally rewrite the deeply entrenched, complex dynamics of how commercial insurers reimburse for drugs, or how massive pharmaceutical manufacturers incentivize those payers through the opaque rebate system.
It creates a viable alternative pathway for many, but it is not necessarily a complete systemic replacement for the existing multi-trillion-dollar insurance machine.
Okay, let's bring this all together. We have covered a truly massive amount of ground today.
We are witnessing a monumental historic paradigm shift in exactly how we get our medicine in this country.
The pharmaceutical supply chain is slowly, agonizingly, but definitely moving away from a dark, broken system defined by opaque rebates, hyper-fragile offshore supply lines, and total PBM dominance.
We are visibly moving toward a future defined by advanced domestic robotic manufacturing AI integration and radically transparent cost-plus economics.
We are seeing independent community pharmacies thrown a vital lifeline, and everyday patients saving thousands of dollars on life-saving generic drugs. This shift from opaqueness to transparency is real, and it is accelerating.
This raises an important question for you to ask yourself regarding your own healthcare footprint. Take a hard look at your employer's insurance plan.
Look closely at your deductibles, your copays, and the specific rules regarding where you are allowed to fill your prescriptions.
Ask yourself, and maybe even ask your HR department, are you unknowingly paying inflated out-of-pocket costs at the pharmacy counter just to subsidize corporate rebate checks?
Are you the one secretly funding the regressive tax of modern healthcare?
The tools for absolute price transparency now exist in the open market. The onus is increasingly shifting onto employers, plan sponsors, and individual patients to aggressively demand that transparency from their benefit providers.
Absolutely. The curtain has finally been pulled back, and we simply cannot unsee how the machine actually works. But I want to leave you with one final provocative thought to mull over.
Something that builds on everything we've dissected today, but pushes the implications a step further into the future.
If transparent cost-plus pricing becomes the universal mandatory standard, if Mark Cuban's vision completely wins out and the massive inflated profit margins generated by PBMs and complex patent thickets are entirely wiped out of the system,
what happens to the billions and billions of dollars required to fund the next generation of breakthrough miracle drugs?
Developing a novel gene therapy or a cure for Alzheimer's requires immense high-risk capital. Will true ruthless price transparency accidentally kill the massive financial incentives required for future clinical innovation?
It is a heavy question to think about the next time you pick up a prescription.
Thank you so much for joining us on this deep dive. We will catch you next time.